problem. How does that relate to this whole idea of psychoeducation, where you already give a certain conceptually, more or less ready-made conceptualization of the problem?
Yeah. So there's one thing I can start by saying that the way the UP is constructed is actually 5 core modules. So the 7 modules you're discussing probably included the psychoeducation module, and then also might have been the relapse prevention, or perhaps the motivational interviewing. So it's really 5 core modules. This is described in the newer treatment manual, the therapist guide. We talked a little bit about the core modules, but the psychoeducation piece, actually, a lot of it is accomplished during the first I would say the first session. What you're talking about is a little different, actually, than psychoeducation. Psychoeducation we cover primarily in the increasing and present focused awareness, and also on discussion of tracking of one's emotions. So that's really, I would say, probably about session 3, we start talking to patients about what their emotions are and how to think about them. And we talk about the 3-component model, and we sort of discuss the ways in which they can track their emotions. So that's more of, we talk more about kind of, what are emotions. In the first session of the treatment, we talk with them about their diagnostic, we talk to them about their diagnoses, and we go through and discuss sort of how those problems have been there for them. So this is kind of that shared appreciation for what the problem is. And as you said, you kind of start working towards that shared conceptualization of, well, what's causing it and what's maintaining it most importantly. And this brings it around to some psychoeducation in the sense that we start discussing, things like negative reinforcement. The idea that if the person is experiencing their emotions in certain ways, and then they do something, to try to calm themselves down or to reduce their emotional experience, they may in fact be building it up. They may in fact be perpetuating it in some way, right? And that may not be adaptive for them. So that usually happens, I would say, within the first couple of sessions. You see it a little bit in the MI, more in the enhancement, the motivation enhancement module, but it starts really from session 1 for us. But I think that you're right, and that you do have to have a shared conceptualization. And again, that is in part just being a good clinician. You have to be able to sit down with a person and work with them on understanding what is the problem, why is this problem there, and then here's our treatment. Like, this is the way that we can go about addressing that, is because we have a shared conceptualization, a shared understanding of what the problem is. I tell the young clinicians that I supervise, if you don't have that shared conceptualization, they are not going to come back. It's just, you're not going to make it that far. You're not going to have an opportunity to really administer the dose of the treatment that you're trying to administer. They're not going to be able to receive it. So I totally agree with you that in the first several sessions, that kind of shared conceptualization has to come out and has to be there. Now, one thing I do have to say is, it's a little bit of we may be cheating a little bit here, but when we administer this protocol, typically those individuals have already underwent an initial assessment. And our initial assessment at our center tends to be a pretty extensive assessment, maybe upwards of, for some individuals, upwards of 4 hours of kind of interviewing and that type of thing. And so by the time I get to see them as a clinician, they've already gone through this whole process where they're presented with lots of different symptoms, and even they're presented with their diagnoses by the individual that conducted the assessment. Sometimes it's me, sometimes it's another clinician, so that we have something to work from. We can sort of say, oh, here are the symptoms, here are the things that you're reporting and that are bothering you, and we can kind of then work towards trying to understand, well, why are these things there? Like, how did they develop? And we do talk about, to some extent, kind of shared, we talk about kind of ideological factors. We talk about, like Barlow's triple vulnerability model, like how do these things kind of get established? And from there, we then work towards, what can we do about it? And usually it's, if we can get to a point where the patient understands why we're doing what we're doing, then I think we're in a much better position to then move on with the additional modules.
as a rule, is the therapist also the person who did the diagnosis, or as a rule, someone else does the assessment?
There's no set procedure for that. I would say that by and large, the clinician is not the person who conducted the assessment. But you can understand the advantages of doing that, I'm sure. Personally, I like to be the clinician who does the assessment. But it's just the structure of our center doesn't really allow for that.
Okay, thank you for this.
Yeah, absolutely. Does that answer your question?
Very much, very much. So, if I try to formulate it for myself, in a way, the case conceptualization is already starting from the moment that you begin an assessment. So maybe one would have to think about this, whether it's, I don't know, whether there should be a clear distinction between the assessment and the therapy, or whether it's desirable that it would be a kind of more integrated kind of work, where you start with assessment or case conceptualization. In my view, part of case conceptualization is assessing all those functions that are important in order to together build a common conceptualization. So I would not want to make this very sharp distinction between assessment and therapy, but would like to see it as an integrated system.
I would totally